Introduce myself. So I'm a Director of Digital Transformation in the School of Health Sciences. So I have a particular focus on developing education to support digital transformation in the NHS and across the healthcare sector. And that's keeping us fairly busy at the moment. As you can imagine, this has really taken off. Anyway, I shall share my screen. Let's hope this works. Okay, can everyone see my slides? Fantastic. Okay, so one of the things that I can't see now is they're actually on the screen. So let's just, okay. Of course, it never works quite as it did in the practice, does it? Because my screen's over here. But anyway, not to worry. So if I'm looking this way, it's because the slides are there. However, so what I want to talk about is working with patients to give them control of how their data is used. And can you see the next slide now? Is that working okay? Okay. So health data is everywhere. This is a mugshot I've taken of my husband here, who is a self-professed data geek. So you can see he's wearing his favorite t-shirt. Data is the new bacon. There's a picture of my favorite new toy that I got for Christmas, my new Garmin watch. And there's the app that accompanies it that I never remember to look at, that monitors my steps on a daily basis, that makes me feel really bad when I've not moved from this seat that I've been sitting in for approximately what feels like a year now. Well, it is a year, in fact, actually, as Colette said, we've now all been working remotely for a year. So data is everywhere. And actually, you know, we only have to put on the news app on our phones, watch the news, the various reports that we've been watching over the last few months, in fact, the last year, really, since the pandemic really started. And we see data's there. You know, Boris said a few weeks ago, we will be guided by the data, and he's going to be focusing on data, not dates for lockdown easing. You can see there, we hear about things like the R number in the press quite regularly now. This is a little infographic you can see at the bottom of the screen. The blobs mean the number of cases across Europe of COVID, and quite regularly we see, you know, data plots showing us number of cases, number of vaccinations. So data, we are surrounded by this health data, and actually it's governing the decisions that control that how we can operate within our lives at the moment, as we're all too aware. So taking a little bit of a step away from thinking about that sort of background of health data, I just want to sort of delve into our own personal electronic health records and just give a bit of context for this talk. So we're all fairly familiar with going to our GP. When we go to our GP, you're quite used to having a conversation not only with them, but whilst they're entering data into their PC most of the time. And this is capturing your electronic health record or your electronic patient record. And so it's got your medical history, your prescriptions, any referrals that you might have had to have had, results from blood tests, for example. And sometimes this data may need to be shared with other hospitals if you have to be referred for a particular condition you might have, for example, or in fact, even if you move house, this data has to be shared with another GP surgery. But the important thing is here, not only is it obviously helping your own health and govern your own direction of your own health and care, but it's a rich source of data that we can use for research and for planning services and the delivery of services. So just moving on from that, I want to just talk a little bit around models of consent. So this comes into play because it's thinking about how we can actually use our health data. And then I want to get to, you know, how health data has been used during the pandemic. So very briefly, there's kind of three models of how consent work. So there can be informed consent, and a good example of that is clinical trials. So we might, if we decide we want to be involved in a clinical trial, a health professional will have a conversation with you. They'll give detailed information about how that trial's working, and you'll be given clear opportunities to ask questions, and you will decide if you want to participate in that trial. And that's informed consent. Then we can have an opt-in version of consent. So this is where you have to actively sign up to a particular activity or receiving more information. So this might be something like subscribing to a mailing list from your GP, for example. And then there's something that we call opt-out. And this is where data can be collected and used automatically unless a person a person actively dissents or opts out of that process. And a good example of that kind of situation is organ donation. So in the last couple of years, both within England and Wales, we've moved to an opt-out version for organ donation. So where am I going with this? Well, this, I want to talk really about the national data opt-out and what's happened with our electronic health records and our data records, and then what's happened during COVID. So on the left-hand side, you can see a picture here. This is the late Dame Fiona Caldicott, who was our national data guardian. Sadly, she passed away a few weeks ago now. But many of you might have heard of Dame Fiona Caldicott. She undertook a huge review back in the late 90s of how we use patient identifiable information, and has written a lot of guidance and undertaken various reviews in this regard. And then this in particular, around 2016, she began a review looking at the sharing of patient data, and a large public consultation was done on that. And I want to draw your attention that there were 7 Caldicott principles that she established. I've not got time to cover those today, but the most important one in the context of what I want to mention is the one that says we must inform patients and service users about how their confidential information is used. And this got us to this you may have seen, maybe if you've been in your GP practice, this poster, or in a hospital, your data matters to the NHS. So what happened as a result of the review and this consultation was that in 2018, she made a recommendation to the Secretary of Health and Social Care that your health data will be used for research and for planning of clinical services unless you opt out. So this is the model we're in now, an opt-out model. Okay, so where does your data go? So this is a very simplified sort of example of what the data flow is. So your general practitioner or the hospital that's obtained your data will transfer your health data via very secure services and networks through to NHS Digital. And essentially you can think of NHS Digital as being a data guardian for the NHS. And it very carefully manages data access requests. So if anyone wants to do research or plan for clinical practice development, they have to submit a data access request. Some examples of people that, organisations that might want to do that. So you might have councils wanting to improve public health, the general population health that they're looking after. You might have a commercial company. We've seen a lot around commercial companies developing vaccines, for example, in the last few months. Or you might have a university such as ourselves who's wanting to focus and develop a new therapy. So they're the sorts of examples of organisations that might make a request. And in fact, you can look on NHS Digital's website at all of the data requests that have been made and who they've been issued to. That's completely in the public domain. So what happened since COVID? Well, there was this thing that was came through called the Control of Patient Information. And this was a letter that was sent from Matt Hancock to all of the GP practices, and it's been called, shortened to the COPE notice. And this was issued back in March last year, and it's been renewed twice since. And this COPE notice basically said that on the basis of the pandemic, a public health crisis, there was a legal basis for using and sharing and linking data for COVID-19 purposes, so to plan services, to do research, important research, which has kind of got us to managing the pandemic as we are now. So this notice happened. So to give you an example of then what happened with that data, so a general practice will have passed on our data to the NHS Digital. The University of Oxford, for example, has been involved in a lot of research work, as have we at the University of Manchester, and they would have put a data access request into NHS Digital to do this research. And what they wanted to do was actually take the data in our electronic health records and model all of the patients that were at particularly high risk of complications as a result of contracting COVID. They undertook that research, and then they created the shielded patient list. So on the basis of those predictions, they modelled through and worked out who would be at particular risk of developing complications. That information was sent back to GPs, and in fact, then people have been contacted to be advised to continue shielding over the last couple of months, and that created the shielded patient list. So that's an example of actually what's happened. So you can see things have changed slightly. We moved from an opt-out to a public health crisis where all of that data was being shared for those very specific purposes of research and clinical service planning. So is it a case of sharing, is it all or nothing? Well, there is somewhere in between, and we've been looking at this in some of our research within my particular area of interest, which is the area of dynamic consent. So this is where patients or participants involved in research can actually control which data and with whom their data is shared. And this might change over time, you might change your preferences, but it gives participants in that research study much more control over the privacy and the access to their data. And the data controllers, so the people that are involved in the study, actually have to be really careful that they comply with whatever those preferences are of those research participants. So this needs really careful supporting guidelines, and it needs policy and, importantly, quite technical infrastructure in the background to manage all of that system. But the overall aim is to improve trust in data use by giving increased transparency and control to research participants. So I'm conscious of time, but we have also done a little bit of work, particularly in the area of genomics, which is my area of interest, which has been led by my colleague Lamis Hassan, who I think I noticed is on the call as well today. So we looked at actually sharing our genomic data with participants and members of the public and what patients and the public thought about this. So genomic data is a little bit different sometimes, because obviously it can also be, some of it can be passed on to family members. So there are some nuances there. But generally, when we looked at this and explored it in a kind of citizen jury environment, there was support for data sharing within regional NHS genomic medicine services. People naturally connected care and research together. People recognised that there were some issues around privacy and security risks, and there was very much a concern and an expectation that access to that data would be restricted to appropriate people for appropriate purposes. And of course, as happens quite often, there was some concern about future uses and mission creep, so the impact of sort of privatisation of the NHS, for example. So what else have we done? Well, we've been looking at actually something called blockchain that you may have heard of in relation to the cryptocurrency Bitcoin, but actually blockchain's not just about sharing cryptocurrency. You can actually use it to model and quite complex data transactions. So we've developed it with our PhD student, myself, Professor Andy Brass, and our PhD student, as a system to share and manage data transactions within a blockchain environment. So its key features are that it can deal with different types of, in our case, genetic data. So that might be your blood type, for example, and actually the instructions that control your blood type, so your genes. It also gives control to the patient over which data they access and who they give access to, and actually for what purposes. So, for example, you could say, I want to share my blood type with a clinician for improving my own care, or I want to share it for the purposes of improving somebody else's care. And importantly, the patient can update their preferences over time. So it's a dynamic process. So my key messages, I guess, from my talk today are that sharing of data is important to improve care and for research purposes, but it needs to be underpinned by very careful consultation with public and patients, and policy and transparency and public trust in any new approaches that we might develop or any policy are really important. And I'll leave you with a question, I guess, which is, well, should the sharing of data for COVID purposes, as we've talked about in that COPE notice, actually extend beyond this situation that we're in right now? We've got other crises that are on the agenda around antimicrobial resistance, health inequalities. So is there a case to be made that actually we should share this data on a much more longer term basis? That's my email if anyone's got any questions or wants to chat. There's some really useful websites that are really accessible called Understanding Patient Data, and I'd encourage you to have a look at that website, and Use My Data are really good too. So thanks very much.